Neurogenic bladder dysfunction, also called neurogenic lower urinary tract dysfunction, or NLUTD, is impaired bladder storage or emptying caused by damage or disease affecting the nerves that control the lower urinary tract. It disrupts the coordinated interaction between the detrusor muscle, bladder wall, urethral sphincters, and the central peripheral nervous system that normally allows low-pressure filling and voluntary complete emptying. It is common in neurological conditions and carries risks of recurrent urinary tract infections, UTIs, kidney damage from high pressures, reflux, or stones, autonomic dysreflexia in spinal cord lesions above T6, and reduced quality of life. Classification and pathophysiology. Dysfunction patterns depend primarily on the location of the neurological lesion. Suprapontine lesions above the pontine micturition center, e.g., stroke, Parkinson's disease, brain tumors, cerebral palsy, loss of cortical inhibition, detrusor overactivity, involuntary contractions with generally coordinated sphincter function. Symptoms often resemble overactive bladder, urgency, frequency, urge incontinence. Suprasacral spinal cord lesions between pons and sacral cord, S2 to S4, e.g., traumatic spinal cord injury, multiple sclerosis involving the cord, loss of coordination between detrusor and sphincter / detrusor overactivity plus detrusor-sphincter dyssynergia, DSD. High bladder pressures are common and dangerous for the upper tracts. Lesions above T6 also risk autonomic dysreflexia. Sacral or infrasacral lesions, conus medullaris, cauda equina, or peripheral nerves, e.g., cauda equina syndrome, diabetic neuropathy, pelvic surgery, spina bifida, detrusor underactivity or acocontractility, flaccid areflexic bladder plus or minus sphincter weakness, results in incomplete emptying, retention, and overflow incontinence. Mixed patterns are frequent, e.g., in multiple sclerosis or progressive diseases. Functionally, bladders are often described as overactive, spastic hyperreflexic, small capacity, involuntary contractions, underactive, flaccid, hypotonic, large capacity, poor or absent contractions, mixed. Normal micturition relies on the spino-bulbospinal reflex coordinated by the pontine micturition center, with higher centers providing voluntary control. Disruption at any level produces the patterns above. Common causes: spinal cord injury or myelomeningocele spina bifida, multiple sclerosis, stroke/cerebrovascular accident, Parkinson's disease and other neurodegenerative disorders, diabetes mellitus, autonomic neuropathy, cauda equina syndrome, often from disc herniation, brain or spinal tumors, trauma or surgery, peripheral neuropathies, alcohol, vitamin B12 deficiency, etc. Congenital anomalies. Any condition interrupting afferent or efferent signaling to the bladder or sphincters can be responsible. Symptoms. Symptoms vary by type and severity. Storage problems, urgency, frequency, nocturia, urge incontinence. Emptying problems, hesitancy, weak stream, incomplete emptying, retention, overflow incontinence, constant dribbling. Reduced or absent sensation of bladder fullness, recurrent UTIs, stones, or, in severe cases, kidney impairment. Sexual dysfunction is often associated. Erectile dysfunction in men, orgasmic difficulties in women. In spinal cord injury above T6, bladder distension can trigger life-threatening autonomic dysreflexia, severe hypertension, headache, sweating. Diagnosis evaluation is individualized but typically includes detailed history, neurological exam, and bladder diary, post-void residual urine measurement, ultrasound or catheterization, urinalysis and culture to rule out infection, renal ultrasound or other imaging to check for hydronephrosis, stones, or upper tract changes, serum creatinine, kidney function, urodynamic studies, filling cystometry plus or one-a-size pressure flow, and video urodynamics, gold standard to characterize detrusor activity, compliance, capacity, and sphincter coordination. Video urodynamics is preferred in high-risk patients. Cystoscopy when structural issues are suspected. Neurophysiological tests in selected cases. Guidelines AUA, SUFU, EAU emphasize early risk stratification based on etiology, urodynamics, and upper tract status, and regular surveillance to protect the kidneys. Management goals are to protect the upper urinary tract, low storage pressures, complete emptying, achieve continence, prevent complications, and maximize quality of life. Treatment is highly individualized and often multidisciplinary. conservative and first-line approaches, behavioral strategies, timed voiding, bladder training, fluid management when cognition and hand function allow, clean intermittent catheterization (CIC), preferred method for incomplete emptying, performed several times daily, indwelling catheters, urethral or suprapubic only when CIC is not feasible, higher infection and complication risk, pelvic floor muscle training in selected patients with preserved voluntary control, e.g. after stroke or an MS, pharmacological, antimuscarinics, oxybutynin, tolterodin, solifenacin, etc., or beta-3 agonists, mirabegron, Vigron for neurogenic detrusor overactivity, alpha blockers to reduce outlet resistance in some cases, botulinum toxin A, Botox injected into the detrusor for refractory overactivity, highly effective and widely used. Avoid routine parasympathomimetics for underactive detrusor, limited evidence. Minimally invasive advanced. Neuromodulation, sacral nerve stimulation or tibial nerve stimulation in selected patients. Intradetrusor botulinum toxin as noted above. Surgical when conservative measures fail or high-risk urodynamics persist. Bladder augmentation, enterocystoplasty to increase capacity and reduce pressures. Urinary diversion, continent or incontinent in complex cases. Sphincter procedures or artificial urinary sphincter for stress incontinence with ability to catheterize. Sphincterotomy or stents for refractory DSD in some spinal cord injury patients. Lifelong surveillance is essential. Regular upper tract imaging, urodynamics as indicated, renal function monitoring, and UTI management. Sexual and bowel function should also be addressed. Prognosis and key points, with modern management focused on low-pressure storage and complete emptying, many patients maintain good kidney function and quality of life. Outcomes depend on the underlying neurological condition, timely diagnosis, adherence to catheterization or medications, and prevention of complications. Guidelines from the American Urological Association (AUA) South U continue, and European Association of Urology (EAU) stress patient-centered multidisciplinary care with protection of the upper tracts as the highest priority. Anyone with a neurological condition who develops new urinary symptoms should seek prompt evaluation by a urologist or neurourologist, as early intervention can prevent irreversible damage. Causes of neurogenic bladder dysfunction. Neurogenic bladder, also called neurogenic lower urinary tract dysfunction, occurs when nerve problems disrupt the signals between the brain, spinal cord, and bladder muscles, sphincters. This interferes with normal storage and emptying of urine, leading to overactive, spastic, underactive, flaccid, or mixed patterns depending on the location and nature of the neurological damage. Causes fall into several broad categories. The specific bladder behavior often depends on whether the lesion is above the pontine micturition center, suprapontine, between the pons and sacral spinal cord, suprasacral, at the sacral level, or in the peripheral nerves. Congenital, present at birth, causes spina bifida, myelomeningocele, neural tube defects affecting the spinal cord, sacral agenesis, incomplete development of the lower spine, cerebral palsy, other birth defects involving the spinal cord or nervous system. These are among the most common causes in children. Nearly all people with spina bifida experience some degree of neurogenic bladder. Central nervous system, brain and higher spinal conditions. Stroke, cerebrovascular accident, Parkinson's disease, multiple sclerosis, MS, and related demyelinating or neuroinflammatory disorders, brain or central nervous system tumors, traumatic brain injury, dementia and Alzheimer's disease, amyotrophic lateral sclerosis, ALS, normal pressure hydrocephalus, encephalitis, multiple system atrophy. These often produce an uninhibited or overactive bladder due to loss of inhibitory control from higher centers. Spinal cord and lower spinal conditions, spinal cord injury or trauma, e.g. from accidents, falls, spinal cord tumors, herniated discs or spinal stenosis compressing nerves, transverse myelitis, cauda equina syndrome or conus medullaris lesions, spinal surgeries or other traumatic injuries to the spine. Injuries above roughly T12 often lead to a spastic bladder with possible detrusor-sphincter dyssynergia. Sacral level lesions more often produce a flaccid araflexic bladder. Peripheral nerve damage, neuropathy, diabetic neuropathy, long-standing diabetes, alcohol-related neuropathy, vitamin B12 deficiency neuropathy, nerve damage from pelvic surgery, syphilis, tabes dorsalis, other neuropathies, e.g., from heavy metal poisoning, certain infections, Guillain-Barré syndrome, or herpes zoster. These typically affect the nerves directly supplying the bladder and can cause underactive bladder, impaired sensation, or chronic overdistension. Other or mixed causes: infections affecting the nervous system, heavy metal poisoning, genetic or degenerative nerve disorders. Combinations of the above, many conditions produce mixed, flaccid, spastic patterns. Any condition that interrupts the neural pathways controlling micturition can contribute. Bladder outlet obstruction, e.g., from prostate enlargement, can coexist and worsen symptoms. The exact pattern of dysfunction, overactive with urgency incontinence, underactive with retention overflow, or mixed, sometimes with detrusor-sphincter dyssynergia, depends primarily on the site and severity of the neurological lesion rather than the specific disease name. Diagnosis typically involves history, neurological exam, urodynamic testing, and imaging of the relevant neural structures. Management focuses on protecting the upper urinary tract, improving continence or emptying, and treating the underlying condition when possible.